Hello students, I am Dr. Vidya-mitra and today I will be dealing the chapter on maternal physiological changes during pregnancy. Dear students, let us know about pregnancy. Pregnancy is in which human life begins and develops to birth. A whole life begins at conception. The fertilized egg, the zygote, starts its multiplication after 30 hours and within 4 days the zygote with 64 to 128 cells arrives the uterus and it implants itself into the uterine lining. By about 2 weeks it is known as embryo. The embryo develops obtaining nourishments through placenta. The placenta takes care of the growth, respiratory and excretion function of the embryo. By about 5 weeks the internal organs like heart, buds of limbs, arms and legs and eyes are formed. By this time the embryo is mentioned as fetal. How does maternal nutrition influence the fetal growth? A woman's nutritional status, prior to pregnancy and throughout the prior of pregnancy decides the health of the newborn baby. Maternal nutritional status is the foundation of the newborn baby's health. Maternal health is controlled by genetic, social and economic factors and environmental conditions. For optimal pregnancy outcome, nutrient store, good eating habits and proper weight gain has to be ensured by the mother. Maternal nutrition affects the child probably even before conception and certainly throughout pregnancy. Objectives of this lecture is to understand the development of fetal growth and importance of nutrition in fetal growth, and to describe the various physiological changes during pregnancy. Let us now discuss the stages of human fetal growth. After the ovum is released from the matured follicle in the ovary, it enters the fallopian tube. It moves slowly through the tube towards the uterus, encountering potentially fertilizing sperm along the way. Fertilization usually occurs in the fallopian tube within 48 hours, after which cell division rapidly proceeds, resulting solid ball of the cells. The morula then enters the uterus, where it undergoes reorganization into a hollow ball, the blastocyst. The blastocyst ultimately buried itself in the endometrial lining of the uterus, that is 5 to 7 days post ovulation. There, the precursor cells of the placenta begin to arrange themselves into a functioning placental unit. Nutritional support from the embryo at this time comes from the endometrial lining of the uterus. After its initial development, the placenta grows rapidly throughout gestation. By 34 to 36 weeks, the fetus completes cell division. From that time until term, growth continues only by increase in size of the existing cells. Embryologic studies indicate 3 stages of fetal growth. Now, let us learn the stages of fetal growth, and the first one is the blastogenesis stage. The fertilized egg divides into cells that fold in on one another. An inner cell's mass evolves, giving rise to the embryo and outer coat, the trophoblast, which becomes the placenta. This process is completed about 2 weeks after fertilization. The second one is embryonic stage. This is the critical time when cells differentiate into 3 germinal layers. The ectoderm, outer layer, gives rise to the brain, nervous system, hair and skin. The mesoderm, middle layer, produces all of the voluntary muscles, bones and components of the cardiovascular and excretory systems. The endoderm, inner layer, forms the digestive and respiratory systems and glandular organ. By 60 days gestation, all of the major features of the human infant will be achieved. And the third one is the fetal stage. This is the period of most rapid growth. From the third month until term, fetal weight increases nearly 500-fold from 6 grams to 3000 to 3500 grams at birth. Measurement of DNA and protein in embryonic and fetal tissues show that embryonic growth occurs only by increase in number of cells, that is hyperplasia. Fetal growth continues in cell number, but now also involves increase in cell size, hypertrophy. Let us discuss about the physiology and picturizes what it is all about the physiological changes during pregnancy. A new life begins at conception, organ system develops rapidly, and nutrition plays many support roles. Pregnancy from conception to birth lasts for 40 weeks, that is 10 lunar months menstrual cycles in women. During this period, the fetus grows from a single cell to an infant that is ready for life outside the womb. Changes in the mother are anatomical, physiological, and complex, affecting almost every function of the body. An integral part of the maternal fetal system increases the most favorable environment possible for the developing child. Now let us discuss the different physiological changes. That is, under the blood volume and composition, the first one is plasma. In a non-pregnant woman, average plasma volume is 2600 ml. Plasma volume begins to increase by the end of the first trimester and reaches a peak by 34 weeks. The physiological dilution accompanies the expansion in blood volume, which is known as hemodilution. Hemodilution is responsible for the decline in several blood parameters during pregnancy, especially in the second and third trimesters. Researchers have shown that increase in plasma volume is correlated with obstetric performance. They found women who have a small increase when compared with the average are more likely to have stillbirth, abortion, and low birth weight babies. The next one is, let us know about the red cells. Production of red cell is stimulated and their numbers gradually rise. There is an increase in red cell mass by 20%. The amount of hemoglobin in each red blood cell does not change, but because there are fewer red blood cells per 100 ml of blood, hemodilution occurs. As we all are aware, normal values which has been recommended by WHO is 12 to 13 grams per 100 ml can drop as low as 10 to 11 grams per 100 ml in the early months, indicating anemia. But in pregnancy, the red blood cells are normochromic and normocytic. Moreover, levels of certain nutrients can be influenced by a number of maternal factors which are very important, such as age, parity, smoking, and the use of various medications before or during pregnancy. The third one is regarding proteins, which are very important nutrients. Total serum protein gradually decreases along with a sharp decline in albumin. Serum albumin decreases with the expansion of plasma volume. Serum levels of vitamin C, folic acid, vitamin B6 and vitamin B12 follow the decline of serum albumin levels. Regarding the other nutrients, the fat soluble vitamin concentration, especially the carotene and vitamin A, are increased up to 50%. vitamin A levels remain unchanged. Progressive increase is seen in serum triglycerides, cholesterol and free fatty acids brought by decreased concentration of estrogens, progesterone and placental hormones. Do you know that many hormones undergo changes during pregnancy? So, let us learn about what are the hormonal changes in pregnancy. The pregnant women secrete more than 30 hormones throughout gestation. Most hormones are proteins or steroids that are synthesized from precursor such as amino acids and cholesterol in endocrine glands. The production is influenced by the mother's health and nutritional status. Some of the hormones that exert important effects on nutrient metabolism are summarized, which is shown in table. Let us now detail each hormone that undergo changes. So, what are the hormonal effects on nutrient metabolism in pregnancy? The hormones, under hormones, the first one is progesterone. The primary source of secretion is placenta, and the principal effects are: it reduces gastric motility, favors maternal fat deposition, increases sodium excretion, reduces alveolar, interferes with folic acid metabolism. The next one, estrogens. These are also secreted in placenta, and it reduces the serum proteins, increases hydroscopic properties of connective tissues, affects thyroid function, interferes folic acid metabolism. The human chorionic thyrotropin, that is HCT, it is also secreted in placenta, stimulates production of hormone. The HPL, which is human placental lactogen, this is also secreted in placenta. It elevates blood glucose from breakdown of lactogen. The human growth hormone HGH, which is secreted in anterior pituitary hormone, elevates blood glucose, stimulates growth of long bones and promotes nitrogen retention. The TSH, thyroid stimulating hormone, which is secreted in anterior pituitary, stimulates secretion of thyroxine, increases uptake of iodine by thyroid gland. And the next one, the thyroxine, which is secreted in thyroid, regulates basal metabolism rate. The PTH, that is the parathyroid hormone from secretion from parathyroid, promotes calcium resorption from bone, increases calcium absorption and promotes urinary excretion of phosphate. The calcitonin, it is secreted in thyroid, inhibits calcium resorption from bone. Insulin, which is secreted from the beta cells of pancreas, reduces blood glucose level to promote energy production and synthesis of fat. The glucagon, which is secreted in alpha cells of pancreas, elevates blood glucose levels from glycogen breakdown. The aldosterone from adrenal cortex promotes sodium retention and potassium excretion. The cortisones from the adrenal cortex, it elevates blood glucose from proteins breakdown. The renin angiotensin from the kidneys stimulates aldosterone secretion, promotes sodium and water retention and increase thirst. So, the next one is the organ functions. Are you aware that even organ functions also changes during pregnancy? So, we will now learn about the changes in organ functions. The first one is the cardiovascular system. Cardiac output increases from 30% to 50% by 32 weeks of pregnancy and declines about 20% increase at 40 weeks, increasing stroke volume and heart rate. The next, blood volume increases, blood flow changes, arterial pressure decreases, that is in first and second trimester. These adaptations protect the women's normal physiologic functioning to meet the metabolic demands of pregnancy and provide for fetal development and growth. The slight cardiac hypertrophy is probably secondary to the increased blood volume and cardiac output. As the diaphragm is displaced upward, the heart is elevated upward to the left. The degree of shift depends on the duration of pregnancy and the size and position of the uterus. Coming to the respiration. Respiration adaptation occurs during pregnancy to provide both maternal and fetal needs. The enlarging uterus results in increased intra-abdominal pressure and elevation of the diaphragm by as much as 4 centimeters. As a result, thoracic breathing replaces intra-abdominal breathing. Pregnant women breathes deeper, that is greater tidal volume, the amount of gases exchange with each breath, but increases her respiratory rate slightly, about 2 breaths per minute. There is more efficient exchange of lung gases in the alveoli and the oxygen carrying capacity is increased accordingly. Coming to the blood pressure during pregnancy. During the first half of the pregnancy, there is both systolic and diastolic pressure of 5 to 10 mmHg. The decrease in blood pressure is probably the result of peripheral vasodilation from the hormonal changes during pregnancy. Blood pressure tone decreases and peripheral vascular resistance falls. First trimester, arterial pressure fails baseline to evaluate pregnancy-induced hypertension during third trimester. Changes occur in regional blood flow, that is, uterine blood flow increases from 15 to 20 ml per minute in non-pregnant to 500 to 600 ml per minute near term. The next one is, let us talk about renal function. Dramatic changes occur in renal function to eliminate the nitrogenous and other waste products of maternal and fetal metabolism. Effective renal plasma flow increases by 75%. This is one of the earliest physiological adjustment in pregnancy. The glomerular filtration rate increases by 50% in early pregnancy to facilitate clearance of waste products resulting from fetal and maternal metabolism. Increased glomerular filtration rate is also associated with increased excretion of glucose and amino acids, but unrelated to the plasma levels of these constituents. Regarding gastrointestinal function, due to the influence of hormonal changes during pregnancy, it is normal to observe adaptations such as taste changes. Heartburn due to increased progesterone production causes decreased tone of motility of the smooth muscle of the gastrointestinal tract, leading to esophageal regurgitation, decreased emptying of the stomach and reverse peristalsis. Here, even nausea and vomitings are quite common. Constipation due to the decrease in smooth muscle tone, resulting in increased water absorption from the colon. In addition, constipation is secondary to hypoperistalsis, unusual food choices, lack of fluids, abdominal pressure by the pregnant uterus, and displacement of intestines compression. The amount absorbed depends on the amount ingested, maternal stores, and progressively increase in requirements of the fetus. It is necessary to be familiar with the changes that has to be followed during pregnancy. So, what are those changes? That is metabolic adjustment. The major adjustment in energy during pregnancy is a shift in the fuel sources. Fat becomes the major maternal fuel, whereas glucose is the major fetal fuel. Pregnant women gain weight readily without changes in energy intake because water comprises 65% of the weight gain. The BMI rises by 4th month of gestation, normally increased by 15 to 20% by term. The elevation in BMR reflects increased oxygen demands of the uterine, placental fetal as well as oxygen consumption from increased maternal cardiac work. Lassitude and fatigability by slight exertion are the symptoms described by majority of women in early pregnancy. This feeling may persist along with greater need for sleep. The next one is placental transfer of nutrients. Students, do you know from where the fetal receive nutrients? The placenta is transitory structure developing during pregnancy and implanted on the uterine wall. It is connected with fetus through the umbilical cord. The fetus derives all its nutrition from the mother across the placental barrier. If the consumption, absorption and utilization of nutrients by the mother and the transport of nutrients across the placental barrier are inadequate, then fetal malnutrition develops. Dietary inadequacies are a major cause of fetal undernutrition. The transfer of nutrients also depends on the concentration in maternal plasma and blood flow to the placenta. The mechanism of transfer of nutrients across the placental barrier is either simple or facilitated diffusion or active transport, as in the case of transfer across the intestinal brush border. Fat soluble vitamins and electrolyte are transferred by simple diffusion. Glucose transfer by facilitated diffusion by amino acids. Water soluble vitamins and minerals like calcium and iron are transferred by active transport. The role of placenta in promoting fetal nutrition is shown in the table. Students, let us now learn how the placenta helps in transporting nutrients. In this table, it shows the role of placenta in fetal nutrition. So, first of all, it nourishes the fetus. That means it facilitates transfer of oxygen and nutrients from mother to fetus. The next one, it removes waste. That is, it picks up fetal waste products such as carbon dioxide, urea and bilirubin. Next, that is the fetal lung. It performs the respiratory, absorptive and excretory function that the fetus lung, digestive system and kidneys will provide after birth. It is a protective barrier. That is, it protects the fetus from harmful agents which are of high molecular weight including proteins. It transports nutrients and in some cases it can store them. The endocrine gland, it produces several hormones that maintains pregnancy and prepares the mother's breast for lactation. Let us see the weight gain during pregnancy, which we call it as maternal weight gain. The weight gain represents two major components: the products of conception, the fetus, amniotic fluids and the placenta. And the second one, maternal tissue gain, expansion of blood and extracellular fluids, enlargement of uterus and mammary glands and maternal store, that is in adipose tissue. In India, recent studies have shown that weight gain during pregnancy by women from upper and lower socioeconomic groups, that is from upper group 11 kgs and from lower socioeconomic group the average of 6 to 7 kgs respectively. Lower weight gain is associated with increased risk of intrauterine growth retardation and perinatal mortality. When a baby is born full term, that is 39 to 40 weeks of gestation, but has a weight less than 2.5 kg, the baby is referred as low birth weight, which in other words we say LBW. These babies have suffered intrauterine growth retardation, that is retardation in growth in utero. If a baby is born prior to full term and weighs less than 2.5 kgs, it is not to be classified as low birth weight. Such babies are called prematurely born. The developmental trajectory of a preterm baby is quite different from that of a low birth weight baby, and therefore it is important to distinguish between these two. How much a weight should we gain during pregnancy? So let us know about it. The rate of weight gain is as important as the total weight gain. Little gain occurs during the first trimester, approximately 1 kg, and in the second and third trimester, when the fetus grows from less than 500 grams to about 3 kgs, the weight gain should be approximately 3 kg, that is 1 kg per month in the second trimester, and 6 kgs, that is 2 kg per month in the last trimester. These translate to approximately 0.5 kgs per week. Although the total recommended weight gain is different for underweight and overweight women, it should be at a slow and steady rate. Now we must know how much is too much and how much is normal. Women with normal BMI of 25, the recommended weight gain is 11.5 to 16, while for the obese with BMI of greater than 25, the recommended weight gain is 7 to 11.5. In Indian setting, the total weight gain of 10 to 12 kgs appears reasonable. Finally, let us now see the relationship between maternal and fetal nutrition, which is shown in a flow chart. First of all, if there is inadequate food intake and poor nutrient utilization, the outcome is maternal malnutrition. Then next, it reduces the blood volume expansion, and further inadequate increase in cardiac output. Next, decreased blood and nutrient supply to the fetus, which in turn is reduced placental size, then reduced nutrient transfer, and finally the fetal growth retardation. Now we can summarize the whole of the chapter into few important points. Pregnancy occupies a critical place in the life cycle and has health and social importance for individual, families and society. Maternal health is a complex which is influenced by various genetic, social and economic factors, infections and environmental conditions, of which may affect the fetal growth. Physiological adaptations result in improved utilization of nutrients either through increased absorption, decreased excretion or alterations in metabolism. This intergenerational significance has led all societies to recognize this as a special period and to make provisions for their care. These physiological changes contribute towards the increased nutrient demand on the nutritional status of the expectant mother. Through the subsequent chapters, students, now more information can be learnt about the nutrient requirements during pregnancy.